joining us for the National Eating Disorders Association's Parent, Family, and Friends webinar series. Today, we will be presenting the role of nutrition therapy in treating eating disorders. My name is Diana Calagrides, and I'm the Program Manager for NEDA, and will be helping to moderate the discussion. We're very pleased to have with us today our wonderful presenter, Melainie. I'd like to take a moment to briefly introduce her. Melainie Rogers is a registered dietitian and founder of Balance Eating Disorder Treatment Center, which offers outpatient programs treating the spectrum of eating disorders in the heart of New York City. He has worked extensively in obesity research at St. Luke's Roosevelt Obesity Research Center in New York City and developed the nutrition component of the Beth Israel Medical Center weight loss surgery program. Melainie also co-founded and was first president of the IADEP New York chapter, a nonprofit organization that provides education for professionals who work in the eating disorder field. She is currently immediate past president and treasurer. Welcome, Melainie, and thank you for sharing your time with us.
Diana, thanks so much. It's really a pleasure to be here today and doing this presentation for NEDA.
Thank you. So I just want to let everybody know that this webinar will be recorded and archived and made available to view through our website at www.nationaleatingdisorders.org under the Media Center tab. So I'd like for everybody just to take a moment and take a look at the control panel that is available on your screen. You should all be viewing this image on your screen, whether it be on the right or left-hand side. We use this control panel to manage background noise and to have everybody on mute just to reduce any interrupting noises. If you have any questions or comments, you can use the chat feature, the question feature as well. Submit those to us, and we'll go ahead and share your questions with Melainie. And of course, if you're experiencing any difficulties with your audio or screen, please feel free to let us know, and we'll see if we can resolve those quickly. Okay. All right, Melainie, so I'm going to go ahead and give you control and go ahead with
Great.
And thanks so much.
Thanks so much, Diana. Thanks again and welcome everyone. Today I'm going to be walking you through nutrition therapy. I myself, as Diana introduced, am a registered dietitian, and I'll be talking specifically about the role of nutrition therapy in treating eating disorders. And today's agenda, I'll be taking you through anorexia and then onto bulimia nervosa, and finally we'll be looking at nutrition therapy and treatment for binge eating disorder, or BED. So that's they're the broad strokes of what I'm going to be taking you through. And to begin our presentation today, I'm going to firstly just try changing the slide.
It looks like we're on the what is a nutritionist versus an RD slide.
Diana, can you hear me? Sorry, a little bit of technical difficulty.
Sure. Yep, we're on the nutritionist versus an RD slide.
Okay, that's not coming up on my end. Okay. Sorry about that. I'm not. What is a nutritionist versus an RD? A registered dietitian, basically, just for the audience, if you're working with a nutritionist, there we go, it just came up. If you're working with a nutritionist in the treatment of eating disorders, you really need to be working with an RD or registered dietitian. Why? Because your RDs are your trained nutrition professionals. So very simply, RDs have an undergraduate degree in nutrition, and in fact most of us have a master's also in clinical nutrition. We've gone through an internship, a rigorous internship in a hospital setting, usually from 6 to 9 months up to 12 months for some internships, passed a national exam. We're required to meet certain national crediting regulations and to ensure that we're up to date with all the research that's going on. So really the registered dietitian is the person that knows the nutrition piece from a medical training side the best. We often are confused with the word registered dietitian versus a nutritionist. And I didn't know this myself actually until I went into the field, but nutritionists here in New York State, anyone who has done one class of 40 hours can call themselves a nutritionist. So very clearly you can see the difference between a registered dietitian who's someone who's usually done somewhere between 4 to 6 years of college plus an internship versus a nutritionist who is someone who's only done one class. So again, just reinforcing that idea that your registered dietitian is your expert, just like if you had a medical concern, you would go to a trained MD, not someone who called themselves, I don't know, a doctor. But the tricky piece here, or the confusing piece, I think, is that as nutritionists or as RDs, we actually don't like the word dietitian because it sounds too clinical, so we call ourselves nutritionists. So go figure. So if you're confused, there's probably very good reason because of the way we refer to ourselves. But that's just a little bit of an explanation for those out there who are not so sure about what is the training and credentialing behind a registered dietitian, and hence, you know, why should I be looking out for that? I'm going to take you on to the next slide, which is the role of the nutritionist in the, sorry, I'm just having a little bit technical difficulty here. The role of the nutritionist in the team. There we go. So with treating eating disorders, we know that the gold standard is a team approach. By that we mean that when you're seeking treatment for an eating disorder, you're usually appropriately not just seeing one caregiver. And by that I mean if you're working just with the therapist, ideally you would want to add a nutritionist to that team when you're ready to do so. Sometimes you may need a psychiatrist to add to that team as well for medication, and often we would need an MD who could check your blood work, your pulse, your heart rate, and make sure that medically you're okay. So the reason why a team approach is so essential in the treatment of an eating disorder is eating disorders are complicated, and therefore to have a number of members there working with you, we're able to therefore tackle, if you will, each of these varying aspects that go towards keeping an eating disorder in motion and preventing recovery, really. So I like to kind of urge people who are maybe right now only working with a dietitian or maybe only working with a therapist to possibly think about that idea of incorporating another team member to help you be able to cover all aspects of what's going on for you in your struggles. Let's move on to the next slide. Sorry for the delay. I'm just having quite a delay, Diana, on my slides here as I scroll through. Okay, there we go. We've gone a little bit ahead. So here I'm going to be focusing specifically on anorexia, and what I'd like to do is just take you very simply through what is anorexia. I'm sure many people know this. Symptoms are restricting. There is not any binging with anorexia, and there's no vomiting or what we call compensation with anorexia, as outlined in the blue. Later on we'll look at bulimia and binge eating as well. So a quick overview then. What I'm going to be covering with the overview on anorexia is firstly relationship with food. What does that look like? Then I'd like to have a little have a look at and touch upon your brain on anorexia. So very specifically, what do we know happens when someone's struggling with malnutrition, and what happens with your mental health, literally what happens to your brain. Nutritional treatment for anorexia, I'm going to be focusing in on some specifics around that, and then touching upon some challenges of recovery for anorexia. This format, this overview that I've laid out here for you, I will also be covering fairly similar elements for both bulimia and binge eating disorder later on in the presentation. So let's have a look then at You on anorexia. Firstly, your relationship with food. Food behaviors. Okay. I'm so sorry for the confusion here. It's just that my computer is lagging.
Sure. Okay.
And I'm ahead. Okay, let's see if I can get this to come up.
I think one more back, and we'll start from the beginning of the relationship.
Say again, Diana?
I think we have one slide before this for food behaviors. Would you like for me to take over? Got it.
Actually, Diana, would you mind? It might be a little easier for the audience.
Not at all.
Here
we go.
Thank you. Great, terrific. Thank you. So anorexia, your relationship with food. So I've kind of grouped these together with common things that we see here working with our eating disorder clients, our anorexic clients specifically around food. And for family members out there, friends, etc., who are maybe concerned that someone you know and care for is struggling with an eating disorder, you may observe some of these things. So I'm just going to kind of give you an idea of some of the tips that are possible indicators. None of these are diagnostic, of course, but these are some of the trends or behaviors we see. So first and foremost, very obviously, skipping meals or only eating small portions, excuses to miss social events that include a meal. You may find your friend or loved one or daughter or wife saying, oh, I've already eaten, or I grabbed something earlier, or, you know, I'm sorry, I have a headache, I'm not able to make it to dinner tonight. Other examples, avoiding a whole food group. For example, I'm not eating carbs. Obsessive healthy eating or clean eating can also be a little bit of smoke and mirrors for some underlying concerns or anxieties around food. Increased interest in recipes and cooking shows. This can actually get quite obsessive. Extensive questioning of how a food dish is prepared. If you've ever been to a restaurant with someone who has a lot of food anxiety, they may literally grill the, not literally, but metaphorically, they may grill the server about how a dish is prepared, does that have oil, what's on the side, etc. Or often we'll see clients will call a restaurant ahead of time so that they can ask all of those questions in private and secretively, so then when they go out with friends or family, it appears as though there isn't an anxiety about ordering that dish. So there's a few nuances there that indicate a lot of anxiety around food. Veganism or vegetarianism can be a way for people to avoid foods. Certainly I am not suggesting that veganism and vegetarianism are bad and only people with eating disorders follow those eating styles. Not at all. But I'm just giving you some examples of what someone who has a lot of food anxiety may do or say as a way to help diminish having questions asked of them about their relationship with food. Gastrointestinal concerns. Here we'll often see complaints of stomach aches to avoid eating. Also, a thing we see a lot of is allergies or food intolerances, without there being actually a medical basis. This gets tricky too, because by virtue of the malnutrition from anorexia, most of our clients will struggle with motility concerns with their intestines, which means that the digestive process slows down incredibly because the intestinal muscles are atrophied or are lost over time due to malnutrition. So therefore the whole digestive process is compromised and not working as well, and that can cause a lot of bloating, a lot of gas, a lot of discomfort with the GI in and of itself. If we go to the next slide, Diana. Condiment use. This is another flag that we often see, an excessive use of condiments, whether it be heaps and heaps of salt, heaps and heaps of pepper, you know, lots and lots of, for example, hot chili sauce, something that might provide flavor to otherwise bland foods. Or on the other flip side of that coin, sometimes our clients will actually add on a lot of condiments to make the food taste bad, so that by doing so they're protecting themselves from overeating or the fear that they may overeat. There's also usually a great overuse of artificial sweeteners. Splenda and stevia, of course, is the big one right now. Appetite suppressors. These are substances or behaviors that basically take the edge off your hunger or camouflage your hunger. Coffee, diet soda, chewing gum, copious amounts of vegetables. So we see these are the kind of behaviors that we will often see, some or many, with a lot of our anorexia clients. And Diana, we'll go to the next slide. This photograph here, I won't eat, I think is how many people may feel about their loved one who has an eating disorder and is restricting. The sense may be she won't eat or he won't eat. The reality, though, as this is a psychological disorder as well, is the reality is for many of our clients, they actually are not able to eat in the sense of their anxiety is so high and so significant that it basically prevents them from being able to allow themselves to eat. So that's quite different to someone who, that your perception is that they're choosing not to eat. That's actually not the case, and it's a lot more complicated. So, you know, often we'll hear loved ones or well-intentioned family members will say to someone that's struggling, you know, just eat. Why won't you just eat? And I so understand that frustration, because it would appear that that is the solution. But hopefully from today's webinar and some of the other wonderful webinars from NEDA, you'll get a better sense of the psychological components involved that make that so difficult. We'll go to the next slide, Diana. Thanks. So now let's have a look at what happens to your brain when you're struggling with anorexia. So next slide. Thanks, Diana. Sorry, folks, I'm not sure if you can hear me or not.
There you go, Melainie.
There we go. Okay, Diana,
yep.
Can you go to the next slide, please?
Sure.
Okay. Actually, we're going to go back to the photograph of the brain. That's the one. Sorry, this is jumping around, guys. Our technology here is not keeping up with our presentation. So your brain on anorexia nervosa. Now this is only for illustration purposes, but I hope when you see this photograph here, the bottom half of the brain is a so-called normal sized brain. The top half is your brain on anorexia. This picture is meant to surprise, if not shock people, and it's not a literal factual depiction of the shrinkage of the brain, but I do want you to know this. When our clients are struggling with anorexia and their body is malnourished and they lose weight, their organs also shrink in size, including the heart, the lungs, etc. But also so does the brain. Now this is extremely important when we talk about mental health then for someone who's struggling with anorexia. And if you have a look at the next slide, we'll talk a little bit about what happens here. So firstly, as I said, the brain shrinks over time due to the malnutrition. What this means, though, is that in the brain there are receptors, if you will. We call them docking stations, or you can call them that. So when medicine is taken by someone, the medicine specifically docks into these docking stations and thereby causes an effect brain. With the nutrition and the malnutrition, those docking stations, if you will, they change shape. They kind of wilt, if you think of a wilting flower. And therefore the medicine is not able to dock at these target sites. Therefore, even if you're taking medication for anxiety or depression, for example, which is very common with our anorexic clients, they're not able to, the medication is not able to be effective. And this is a really significant and important piece in anorexia, that specifically medications are not able to be helpful when the malnutrition is causing this effect. Hence, as you would think, as you would imagine, there's difficulty comprehending. Thinking can really slow down in our clients. And then we get increases in anxiety. We get an increase in depression. We also get an increase in obsessive thinking and an increase in rumination. Rumination is a type of obsessive thinking where we get an idea or a thought in our head and we keep going over and over and over it. So let's go to the next slide. What we know then, so the body at this point starts to panic because it realizes that it's in a starvation mode. The body goes into overdrive because it has a survival instinct to help us to seek out food and eat food in order to keep the body alive. So what happens here for the anorexic is that they may find themselves bombarded with constant thoughts of food as a result of that really evolutionary drive for survival. So constant calorie calculating, constant planning of what to eat, constant planning of how to burn calories, etc. Numbers, numbers, numbers. And if you go to the next slide, this is my attempt to depict in a picture sense what that would look like. If we can go to the next slide, Diana.
Want to see the animation again?
I wanted to go to the next slide that has woman's head and then a full.
There we go.
There we go. So, sorry if it's anticlimactic. Thanks, Diana. So this is how I would really depict what's going on in someone's head. Constant calculations, constant numbers, back and forth. I have to cut this out, I have to do that, then I can be sure that this is going to be okay. So the main word that comes up for me here when I look at this picture that I'm trying to portray is just enormous anxiety and very, very consuming. A little bit earlier I said that you know, these constant thoughts is a survival mechanism, and in fact from research we know that for our anorexics they can spend 110% of their day thinking about numbers. And I say 110% very deliberately because from the research it appears that some of our anorexic clients actually dream about food. So not only do they spend 100% of their day thinking about food and calories, but they may actually have that kind of invasiveness in their dreams as well, hence accounting for about 110% of their thoughts and concentration. That is what we call white noise and extremely exhausting for our anorexic clients. Let's go to the next slide, Diana, nutritional treatment for anorexia, and on to the next one. There we go. So when we talk about treatment for anorexia specifically, food really is the only medicine initially that helps. Our first port of call is to treat the malnutrition, to treat the wasting that's gone on in the body within the organs as well as the brain. And for many of the psychiatrists out there that you may be working with, they will certainly support the idea that we need to have your brain get back online literally in order for medication to then work. So food really is our first go-to. And then the next slide, Diana, where we'll talk about those 8 stages of treatment. Here I'm just going to walk you through the general 8 steps that I see with treatment for anorexia. And here I'm considering the whole team approach. So this is with our therapists, with our psychiatrists, and often with our MD involved, along with the nutritionist. So first and foremost, as I said, for anorexia, weight restoration is absolutely key to get the brain back online and also to help repair some of the damage to the internal organs. Thinking of the heart there specifically, and all of that is a huge concern before we even think of weight restoration in the sense of rebuilding muscles in your legs or your arms and what we typically think of weight gain. First and foremost, it's really trying to deal with the internal organs and the brain. Stage 2, this is where concurrently or as working with your therapist is going to be absolutely a period of time, maybe a year of body weight. And psychiatric medications may have been introduced somewhere in these steps 2 to 4 after that restoration has occurred. Then if we flip to the next slide, just waiting for that to come up on. Okay, still waiting for that.
I'll go back one and then kick start it.
There we go. Thank you. So stage 5 to 8. So body image. I'm always asked, and I totally understand why, our clients would be worried about when does the body image stress, if you will, start to decrease. And there is some subtle changes in the first little bit, but most significantly we see something very, very significant occur around about the 2-year mark is where we really see a significant change around that body image for clients who are going through the recovery process, because the body image anxiety can unfortunately reinforce the eating disorder behaviours. So it's this part doesn't see months to 2 years into the process. Neutrality with food is a very big step in this overall treatment. Ongoing support to reduce relapse is absolutely essential. And I want everyone to know that recovery, full recovery from an eating disorder is possible. It does take a long time though. Let's have a look at the next slide. And here I'm going to focus specifically on the stages of treatment working with the nutritionist and what we specifically look at. Diana, is that working on your end?
Yeah, we're at the anorexia recovery pathway.
Great,
Maybe.
perfect, thank you.
Or,
Thanks, Diana. This pathway is specifically what I myself as the nutritionist or registered dietitian, these are the steps that I would be taking my client through. So first and foremost, I would be focusing on the physiological restriction that the client is experiencing. By that I mean calorie reduction and not taking in enough food to support the body, so physiological restriction. Once we're able to tackle that piece and help a client in that area, emotional restriction is something that the therapist who's on the team would then start to look at. What role does the eating disorder play in this client's life? Why is it so important? So while those two parts are going on concurrently, we would then help the client move towards developing a greater neutrality with food. Neutrality with food means there are no good foods, there are no bad foods. Food is just food. A salad is just food, as is a slice of pizza is just food. There's no good and bad or judgment there. Intuitive eating is the next step, and this I think is an absolutely essential part of the recovery process. Hunger, fullness, and satiety, H standing for hunger, F for fullness, and S for satiety. This is not a concept that many of our clients have a good sense of when they first present for treatment. In fact, many of our clients are very, very disconnected from hunger or fullness, and certainly not satiety. So our goal is to reintroduce this internal regulatory system to the client and have they need food and how much food they eat in relation to their internal body cues, as opposed to external cues of like a lot of food, calorically that seems too much. Those are all external cues. So we want to get into the internal cues of what is your body telling you that it needs. The fifth box there, healthful eating, and I put an asterisk on that because so-called healthful eating is not a necessary part of the recovery process, which may cause some people to gasp that how can a nutritionist say that? Really good sense that food is just food and they're in a very neutral place with food. Then and only then could we then start to even think about, should I have more vegetables, less red meat, etc. It's only at that place that we could even consider that. Because as you saw earlier, because of the consequences, the significant consequences of malnutrition, the most important thing for us to do in these earlier steps is to help the client regain weight. So calories, not the type of calorie, but literally calories are the most important thing. And I've said to my clients, they may be horrified, but I don't particularly care necessarily if they were to eat Doritos and that's all they ate. There's no judgment here. The calories are more important than the type of food until much later on. And then the last box here, symptom-free, neutral with food, stresses occur in life and there isn't a desire to start restricting again. That's ultimately where we're trying to get our clients to get to. And we'll go to the next slide, Diana.
Sure. Melainie, we actually have a question about this pathway. Somebody had typed in, what if you get into recovery or the process of healthful eating, but the body still cannot digest food?
Yeah, two thoughts there. One is we know that you need to weight restore for about a year before the digestive processes really get back to a place of normalcy, if that's the word. So if you're still not digesting food, I would think one of two things. One, it's either too early in the recovery process, or two, there may unfortunately be something else going on with GI concerns. So that would be when we would want to refer you to a GI doctor to see if there's some food allergy that has come up or an intolerance as a result of the malnutrition. Often we see a lot of discomfort in that first year, but after the body restabilizes, a lot of that discomfort and inability to digest settles down. But that's a long time for someone to struggle with some discomfort.
Great, thank you.
Any other? Yeah. And we'll go to the next slide, Diane.
Yep. There we go.
So weight restoration for anorexia, I have to really emphasize that as important as weight restoration is, it must be slow and steady. In fact, we know from research that fast weight gain leads to a higher relapse risk, which I think for many people is, it kind of makes sense, right? That if you shock your body into this fast weight gain and then just psychologically and emotionally you're not yet caught up with the changes in your body, that can be a really disturbing thing to observe or have happen to you in a way. So we know that slow and steady is definitely the way to go. And that's really hard because people are often very anxious and family members are anxious and they just want someone to gain weight and gain it quickly and get better as fast as they can. So just a cautionary note there. Food choices, as I mentioned, on an individual basis around if someone's walking or they're having a casual run and it's not 2 hours a day every day of the week, as an example. Let's go to the next slide, Diana, where I get into more specifics on the nutritional treatment of anorexia. I'm going to take you through now about 6 steps of literally what I would do with my client in my sessions to get them to a place of eating more food over time. Now these 6 steps actually could take us many months to accomplish. So I'm going to kind of fast forward it here, but if you can keep that in mind. So a client comes in and says, I'm having an apple for breakfast, carrots for lunch, and another apple for dinner, and salad, but it's all greens and there's no regular salad dressing. So pretty much just vegetables. What I would do then with the client's input and collaboration is we would then go to step 2, Diana, the next slide. And this is what we would jointly agree to add on. And the add-on column is on the right-hand side in the blue. So week 1, we might add a cheese stick to the apple and we might add some hummus to the carrots, and that's it. And that may be a shock because obviously the client is still going to be massively under-eating even with these add-ons. But this is a very, very important part of the treatment process, to meet the client where they're at and to do this in baby steps. Because remember, every time a client adds on food, their anxiety goes through the roof. So our goal is to do this at a pace that the client can tolerate. Week 2 is when I then might add on crackers and let's say add on an after dinner snack of yogurt. Let's go to the next couple of weeks with the next slide, Dinah. Thank you. So on the left-hand side, we have now our baseline of what we're eating daily, let's say, as an example. And on the right-hand side, what are we going to add to that? So on week 3, we're going to add in a slice of regular bread to breakfast, and we're going to add in some rice cakes to lunch, and we're going to add a tiny little bit of olive oil into the salad for dinner in week 4. And again, remember that this could be actually month 3, month 4, because it takes a long time to get this, you know, to work on adding these on. So here we are, week 5 and 6. On the left-hand side, we've got a new baseline of what we're consistently eating, and we've now got our add-ons from adding in some peanut butter with our bread in the morning, adding a banana in for a mid-morning snack, and for an afternoon snack, we're also adding in some almonds. So what we've done now is we've added in 2 snacks to the original 3 meals, if you would call them meals. I would call them meal events because they're not real meals just yet. and then we would add on to the food components that we already have. Let's go to the next step, step 5. And here on the left again, this is now our baseline, this is now our foundation, and I consider this a huge success because we have a client eating a breakfast of sorts, a mid-morning snack, a lunch, an afternoon snack, a dinner, and a snack after dinner. This is fantastic. So this is a much better foundation for us to now work on with our next goals around what that food is going to look like. So let's go to the next slide, Diana, and that will show you what we do from here. So what we do from here is we try to make the food events more like real meals rather than a compilation of snacks, if you will. So for breakfast, for example, 2 slices of toast and some peanut butter and apple. Not too bad, somewhat like a reasonable small breakfast, but nonetheless some breakfast foods in there. Banana and a cheese stick sounds great. We've even got a sandwich for lunch, which is huge. Handful of almonds and an apple for a snack, and then we've got some chicken and some vegetables with pesto sauce, which has some oil in it, a cup of rice for dinner, and a protein bar and some yogurt later on. This is so exciting to get to this stage as a nutritionist with a client who started off, as you remember, with just a couple of apples and a piece of salad, a portion of salad. So our add-on goals from here onwards and our work over the next months, if not few years, would be adding on variety, adding on different cuisines. And what I do with my clients around cuisines is, you know, one day we might do a challenge meal of Chinese. The next day it might be Indian food. The next day it may be Korean. And of course sushi is in there as well because that's absolutely part of normal eating. The third point here is we want our portions to be quote unquote normal, and part of the work of the nutritionist is to help a client navigate what is a normal portion, using of course hopefully some of those internal hunger fullness cues that I touched upon earlier. And ultimately our goal is through exposure to many different foods and many different cuisines, we're helping the client develop a more neutral relationship with food. Let's go to the next slide then. Thanks, Dinah. And this is what I see the neutrality road to recovery to look like. So hunger, fullness, satiety cues, developing those. As a client becomes more trusting in, okay, now I'm going to eat, I'm full, I can stop, and doesn't feel out of control with those internal cues, they develop a greater trust in their body. That leads to much less anxiety around themselves and their relationship with food, and that ultimately leads to a neutral relationship with food, or food neutrality. And that's kind of the jackpot. That's really where all this work is trying to take us to. So let's go to the next slide there, Diana, where we're going to touch upon some of the challenges to recovery. Diana, are you able to pull up that next slide?
Yeah, so we went ahead, we're in challenges of recovery, and I've got refeeding syndrome and anorexia. Maybe it may take a couple seconds to
Great, thank you.
Away.
There we go, great. One challenge to recovery, just going by our title here, refeeding syndrome. This is something that we're very careful of when we start working with a client who's struggling with anorexia, when we're reintroducing food, and also when we're increasing the food amounts. Refeeding syndrome, very simply, is when we see abnormally low levels of an electrolyte called phosphate in the bloodstream. We know that it can be fatal. And as I said, it occurs in clients struggling with malnutrition, when food is reintroduced too quickly, or it's stepped up or increased too quickly. So this is something that as clinicians we're very aware of, and our goal therefore is to avoid this refeeding syndrome from happening. And there are several ways we can do that. If we go on to the next slide, Diana, it will actually give us a diagram of what this looks like. So very quickly here, I hope you can understand my diagram. On the left we have glucose from the bloodstream. On the right we have, in the purple, phosphate from the bloodstream. And what happens when you eat a meal, your food gets digested, converted down to glucose. The glucose goes into your bloodstream, as you know, and the glucose goes into cells in your body, and that's how the cells are fed, if you will, and are fueled to continue to keep the body working. Now what happens in a client that's very malnourished, who hasn't had much food in their system? They already have low phosphate in their blood. Phosphate is a normal component found in our bloodstream. When the glucose is taken into the cell, it actually needs phosphate as well to be utilized by the cell. So it draws in phosphate as well, a very natural process. What happens though is there's a sudden draw of phosphate out of the bloodstream, and we end up with these abnormally low levels of phosphate in the bloodstream, which can then cause the symptoms of refeeding and can actually be fatal. So if we go on to the next step there, Diana. So how do we prevent this? The slow, steady increase of food that I've mentioned earlier is absolutely essential. We absolutely need a medical doctor on the team to be checking blood work, to check for those phosphate levels. And in some circumstances, perhaps in a residential facility, if those low phosphate levels are already anticipated, then supplements may be given proactively as we go through that refeeding process. Let's go on to the next slide, where the end weight markers and anorexia. My clients, of course, ask this question a lot. How much weight do I need to gain? What is the bare minimum that I can possibly gain that would still restore my health and allow me to do everything I want to do, to go back to school, to go back to work, to function, to be able to think clearly? The reality is that if you don't fully weight restore, there's an 80% chance of relapse if you don't completely weight restore. That's a very, very, very high rate. In my mind, that's almost a guarantee of relapse. And for females, what we'll see when you're getting close to an end point in weight regain is we'll often see a return of your menses, which is a sign that the body's starting to turn back on some of its systems that it had to shut down earlier because of the malnutrition. And in addition to that, we would be looking for food as an important factor getting close to an end point in recovery. And here's the key thing. The next 3 points are very important. Your optimal weight, whether we like it or not, is actually dictated by our genes. So when a client comes in to me and says, how much weight do I need to regain? What do you think is my best weight? I have, of course, formulas and calculations that I can make and charts I can consult. But those formulas and charts are based upon population estimates. They're not applicable for you, the individual, and specifically your genetic makeup. So myself or anyone on your medical team can't dictate or state clearly an absolute weight that your body needs to be at. And that can be extremely stressful endpoint. When can I stop all this and just get back to life, right? But I think it's so important, and this is where an appreciation of allowing your body to do what's so important. To also not cave into the anxiety and go back to dieting to control your body weight. We know that dieting is actually a gateway, what we call a gateway behaviour to an eating disorder, absolutely be avoided. And in fact, for all of our clients in their recovery process, they know that the one thing to not do in the future is they can ideally never go back to dieting because that would really potentially trigger the recurrence of an eating disorder for them. Let's go to the next slide then.
We're at the "Are we there yet?" slide, Melainie.
Oh, sorry, no, it's not coming up on my end yet.
For a couple seconds.
Okay. Okay, so are we there yet? I mentioned earlier it takes about 1 year for your body to reach. This means for your body to get back in internal organs that we spoke about, including your heart and your brain, to rebuild the muscle that makes up a lot of your internal organs, such as your intestinal system. And it takes about 2 years to be reduced. Is to the recovery process. And for bulimia, it's important to remember, or it may feel depressing, that it takes about 5 to 7 years for full recovery from anorexia or bulimia. Recovery actually is possible, and that you don't have to live with an eating disorder for the rest of your life. I think that's so important to hang on to that particular fact. Let's go on to bulimia then, and I'm just cognizant of the time, and because of the delay with the slides loading here on my end, that we're a little bit behind time, so I'm going to move through the next few slides a little bit more rapidly. So let's talk about bulimia. Let's have a look at that comparison chart that we looked at earlier, specifically for bulimia. Bulimia, as you well know, also includes binging, and it also includes compensatory behaviours such as vomiting, such as use of laxatives, and that's where it differs to anorexia, which is usually just pure restriction. I'm going to be covering is you on bulimia, your relationship with food. So what would be some of the flags that you might see as far as your loved one's relationship with food that may indicate that their relationship with food is not neutral, that there might be some high anxiety going on there? I'm also going to take you through a little bit of the nutritional impact on your body, some of the nutritional treatment for bulimia in a similar way that I did for anorexia, so that we can compare the similarities and also the differences. And then let's have a look at some challenges. So let's go on to the next 2 slides, Diana. Bulimia and the relationship with food. Diagram, you can see at the very top we have the dieting word. Dieting is, can feel like a form of control for our clients, so it can help them to feel more grounded. It leads to hunger, as one would expect. Hunger then can lead to, of course, the body kicks in and says you must eat, so we do. In our bulimic clients, this leads to enormous amounts of guilt. Enormous amounts of guilt that then lead to more eating and, in fact, an overeating event that we would call a binge, which is eating a large amount of food in a short amount of time and feeling unable to stop or out of control. Binging, we know for our bulimic clients, tends to have a numbing effect. It kind of really blankets a lot of the emotions. So this client had high anxiety. After a binge is not really feeling anything much, and that can feel quite good at the moment, at that time. However, there can be enormous remorse that then kicks in and the need to get rid of that binge, and hence a purge is what then can follow. And then from there, there's a sense of I blew it, I messed up, I didn't do it right, let me go back and try tomorrow and diet again, and this time I'll get it right. So let's have a look at the next slide from there. And typically, what kind of food behaviours might you see for someone with bulimia? Certainly by a high intake of food. Large quantities of food may go missing. So if you're living with your loved one or family member, you may know that a lot of food tends to go missing. There can be large food bills. Other behaviours for clients who are bulimic is after a meal they may go into the bathroom, run the shower to provide some noise while they may be in the shower, and the water sound is a way of masking those sounds. Seeking out single bathroom stalls is a common behaviour. We've also had clients who've not had access to a bathroom and so have hidden containers in their bedrooms, which can be really shocking to loved ones, not understanding their illness and what's going on there. Flag, for example, toilets becoming blocked a lot, bathroom sinks becoming blocked, pipes corroding. That can be from a lot of purging activity. Excessive exercise routines are often common, as are weight fluctuations, and also food avoidance and aversions, as we saw in anorexia. I'd like to now step you through some of the physical aspects of bulimia. Now, with bulimia, as we saw in anorexia, some of our bulimic clients certainly can move from anorexia and back to bulimia and back to anorexia. So unfortunately, some of our bulimic clients may experience malnutrition periods, etc., that go along with that, and then they may move back into this bulimic phase. And some telltale the next. Are you able to move us over to the next slide there, Diana?
Sure, Melainie. I'm just scrolling through the different pictures included. Had those come your way up?
Okay. Yep. There we go. Yep. This is an example of a gland, basically, on the underside of your jawbone there, parotid, the parotid area, and we see swelling here, and often we'll see it on both sides. In this case, you're seeing it on one side. And can you go back to 2 slides, Diana, to the hand?
Sure.
Here we go. Calluses on the fingers. This is from someone who has used their hand to induce vomiting, and those marks that are circled there are because of the contact of the knuckle bones with the teeth in trying to induce vomiting. So that's another common sign that you may see on your clients or loved ones, but not always. Some of our clients are able to purge without using the need to use their hands or any such mechanism. They can voluntarily kind of bring up their food. Sorry if that sounds frightening to those who are not familiar with the illness, but that is what we do see. Let's go ahead now, Diana, to talking about potassium and the heart.
All right.
Great. So with potassium and the heart, this is the key piece that we really focus on with bulimia. With constant purging, the electrolytes in the body are significantly affected. And there's one particular electrolyte called potassium that is particularly essential to the beating of the heart. So it makes sense that if this electrolyte decreases in levels in the body, it's going to have an impact on the ability for the heart to beat normally. So as you can see here from the arrow indicating lower and lower levels of potassium, what eventually can happen is that the heart certainly has a harder and harder time beating, and unfortunately, if bulimia is treated appropriately, unfortunately a very dangerous side effect of bulimia is heart attack. So this is certainly what we want to avoid, and it's something that as clinicians, when we're working with our bulimic client, again, just like with anorexia and the phosphorus, checking blood for potassium levels and possibly supplement. Let's go on to nutritional treatment, if you will, Diana.
Sure. We'll go on to the 8 stages of treatment.
Terrific. And these 8 stages of treatment are almost identical to the anorexia stages. So very quickly, stage 1 is symptom reduction. In anorexia, that was all about weight restoration. For bulimia, it's about decreasing the binging and the purging with the end goal of stopping that totally. Therapy, stage 2, stage 3, stabilizing the body weight. Stage 4, psychiatric meds as needed. Stage 5, on the next slide, that body image piece that we spoke about. Neutrality with food, of course, ongoing support, and again, as with anorexia, the wonderful or the hopeful message here, I should say, is that full recovery from bulimia is also possible, which is, I think, incredibly important for people to know and remember. Let's move on to the bulimia recovery pathway so I can walk you through the steps that I would take as the registered dietitian, nutritionist, working with my client on how do we get them from the initial stages of really struggling with their symptoms to get them onto that path of recovery. Can you see that pathway slide, Diana?
Yeah, I went ahead and pulled that up for everyone.
Great, there it is. Terrific, thank you. So again, this pathway is fairly much similar to what we would do for anorexia, with the difference being in the first 2 boxes. Here we're reducing the physiological binges and purges, and while we're controlling for those, i.e. the physical going out seeking food and purging, and then once we're able to kind of stabilize that aspect of the symptoms, if a client then continues to binge and purge after we have worked out the physiological triggers, then we know that some of the binging and purging is occurring due to specific emotional triggers as opposed to physiological triggers. And I'm going to show you a little bit more now about what I mean by that. So my first goal is to separate out what is a physiological binge that's caused by starvation versus what's an emotional binge that is triggered by some upsetting situation, and then I help walk my clients through neutrality with food, the intuitive eating, and on to symptom-free neutrality with food as an endpoint in recovery. And as we said earlier, recovery can take 5 to 7 years. So this process here in 6 colourful steps that we're doing over many years really to get to that end point. Let's go to the next slide, Diana, where I can explain a little bit more about what I mean by physiological binges, purges. So my very crude diagram here is just to show you that morning, blood sugar levels start out, the body is expecting food, it doesn't receive any food. We get to the end of the day, the body is registering that it's starving and it's looking for food. So at that point, again, there's a survival mechanism that kicks in, that constant thinking about food that we spoke about with our anorexic clients. Anyone who is finding themselves in a place of excessive hunger is going to experience that. And the body is going to push you to seek out food and eat food. Now what's so difficult here also is that the body is going to override judgments about what food to eat, i.e. I should just have salad because it's low calorie. It's very difficult at this point to be able to follow that kind of food choices, because what the brain is signaling to the body, seek out food, seek out calories, the more the better. The fried chicken is looking really good right now because that will assure us of adequate calories. So that's just an example of kind of this survival mechanism that is there. It's a very real part of all of us that can then make this binge piece very, very frightening, with a lot of food that you may have regrets. Our clients have regrets eating later. So this overfull experience can then be also filled with remorse and fear of the outcome of having eaten, let's say, fried chicken, and therefore the anxiety gets so high that the client feels that they must get rid of that meal, and hence a purge event occurs. So this is an explanation of a physiological trigger, i.e. not eating all day, that then leads to an overeating or binge event that then leads to purging. Our goal in the next slide is to balance this out to reduce this physiological risk. And as you can see here in this lovely kind of wave graph, what we're ideally trying to do here is not have those blood sugars crash and spike. What we're wanting them to do is gently roll throughout the day so that we have a breakfast, and then as we start to feel a little bit full, we stop, and then after some time our blood sugar starts to decrease again, we're hungry, we eat. We don't eat so much, we eat enough, and then they start to come down a little bit later and we're hungry again. So this is the lovely wave of hunger, fullness, and your blood sugars throughout the day. This is why your nutritionist, your treatment team, is going to continue to promote and talk about the need for 3 meals a day and often 2 or 3 snacks a day to try to continue to have this physiological balancing out of your blood sugars to reduce any kind of physiological. Once a client is able to eat and eat consistently in this way, we know that then if a binge occurs, it's usually because there was an emotional trigger that happened that was not at all related to being excessively hungry. So then we can work on what those emotional triggers are separate to the physiological triggers. So that's a very important piece of the initial stages of treatment. Let's go on to the next slide there, Diana. So I'm going to step you through these next slides fairly quickly, and very similar to what we saw with anorexia. We've got the client coming in for treatment, really here just having coffee in the morning, which we know can be an appetite suppressor. So this client may just drink coffee all day and eat, chew on lots of gum, for example, not eat anything, and actually may even say they're not terribly hungry. Towards the end of the day, they start to get hungry. They start off with some healthy choices, and that may be forbidden or off limits. And also, so that might be bread for some clients, and pasta, and more pasta, cupcakes, chocolate, etc. And I put wine in the mix here because for many of our clients with bulimia, if they drink wine or drink alcohol, they will often tell me that the alcohol makes them more vulnerable to overeat and to then purge. So we call that a disinhibitor. So that may be where the client starts. Let's skip over to the next slide to have a look at what we would do to start to tackle this, reduce this physiological binge purge pattern. So here I would definitely want to get something in the morning, even if it's just a cheese stick, to mark the meal event in the morning. A yogurt and an apple for lunch is fine in these initial stages. I would want to reduce the coffee because of the appetite suppression that's going on, and certainly if there's gum use, you would do the same there. As possible, I would also suggest for now that we might want to remove the wine or only have it on certain occasions so that we're not making the client more vulnerable from that disinhibiting effect. Let's go on to the next slide. And here you can see on the left-hand side what's our baseline, and then we're going to add on. And let's go to through the next couple of slides. We'll just slowly go through those, Diana. So we've got more food items that are our baseline. We're adding on more food items on the right. Let's go to step 5. Here on the left-hand side, we've got a better foundation here of meal events and food items. And as we did with anorexia, we're going to continue to work towards real meals that are evenly distributed out the day. We're going to include snacks under control. Remember the rolling wave graph that we looked at? We're going to avoid really large, voluminous meals. And salad can be a real factor here because you can eat a salad and need to eat a lot of salad in order to meet your needs. And that kind of large volume meal can actually really trigger a client who's struggling with bulimia. That sense of fullness can actually trigger them to lead to then seek out a purging experience. So we want to avoid any large voluminous meals. We also mostly want to therefore separate out beverages or drinks from when you're eating the food so that that meal doesn't become artificially fuller than it actually is. And hence the last point being what I've just described, that we're decreasing that risk of overfull sensation, and therefore we're decreasing that risk of purging. That's our goal. Let's go on to the next slide. And as you can see here, thrilled as a nutritionist with what this day now looks like for the client. And again, this is just a very, very elementary start point. These are very, very what we would call safe foods. And what we want to do from this foundation is now add on more variety, add on different cuisines, the normal portioning I mentioned, the neutrality with food, that if this client went out with friends or to a friend's house and they served pizza, it would not throw them off. If they served, I don't know, if they went out and had Indian food with rich sauces, the client wouldn't be thrown off. These are the goals of developing a neutral relationship with food, and of course balanced meal events throughout the day. Let's go on to the next slide. Some of the challenges then for recovery from bulimia. The challenges can be quite similar to anorexia. Recovery, as we said, it's a very long process. 5 to 7 years is what we believe from the studies. And a very important piece for bulimia that is different to anorexia is stopping behaviours doesn't mean that you're then recovered. That is just the start point, as we saw on my graph there on the pathways. Stopping the behaviours is the first point in the next series of steps of working towards recovery. Body image, as we know, doesn't really shift for quite a while, making this process extremely difficult. It's important to not diet, as we went over earlier. And again, we want to allow at least 12 months for a client, when they've been symptom-free for 12 months, for their body to re-establish its balance, its homeostasis, and to have all of its systems fully functioning again. Again, with anorexia, as with anorexia, recovery is certainly possible. What I'd like to do now is, I'm just looking at the time, I'd like to go into discussing binge eating disorder. And if we have a look at binge eating, how is that different to anorexia and bulimia? So if we look at our comparison chart, binge eating, like bulimia and like anorexia, involves restricting. Like bulimia, it also involves binging. However, unlike bulimia, there is not any compensatory behaviour. So binge eating is a combination of restricting and overeating or binging. What I'm going to walk you through now is what you might see as some of the typical signs of binge eating disorder, as far as if someone's struggling with binge eating, some of the nutritional treatment approaches that I would take, and also some of the challenges for recovery. So let's have a look first at what are some of those signs that you might pick up on in a loved one who's struggling with binge eating. First and foremost, eating large quantities of food in a very short period of time, feeling great distress and out of control. A note to you all, though, is that this type of eating experience, as distressing as it is for our binge eating disorder clients, is often done in private or secretly. There's a lot of shame in the binge events. So you may not ever actually see that kind of eating pattern. Binge eating clients, however, may actually eat very little during the day. One, because often they're not hungry after a binge event at night, and also two, because there's an enormous stigma and shame about eating in public, no matter what that food item may be. Large food bills, as we saw with bulimia, high anxiety with having certain foods available, a very black and white relationship with food. Food choices have a very high moral judgment. In other words, I'm bad, or I'm a bad person if I eat so-called bad or unhealthy foods. Intuitive eating is certainly not a concept for many of our binge eating disorder clients, who have often been raised on diet after diet after diet, and are often of the thought process that they just haven't found the right diet for them yet, or that they lack willpower, wrong assumptions and beliefs for this type of eating disorder. Let's have a look at the nutritional treatment. Now, I just want you to know that for many of our binge eating disorder clients, there is a caloric consequence to the binging, and therefore there is a weight shift over time. However, not all clients who struggle with binge eating disorder are overweight or obese. So that's an important distinction of our clients. Means 20% don't. So we therefore shouldn't just assume, is what I mean, based upon someone's physical presentation. I want to also stress that for our clients with binge eating disorder, there can also be a lot of trauma related to living life in a larger body. There can be a lot of stigma, shame. They've often been bullied. They've often been tormented, made fun of, had snide remarks. I have one client who in winter she felt safe because she could wear a big coat and therefore didn't feel as exposed. But in the summer, when she had from her home to my office for her nutrition session, was an extremely challenging and frightening and traumatic experience on many occasions. I mean, I just can't even imagine how difficult that must be, or fear of anticipating someone may say something about your physical size and therefore judge you morally. Extremely important. Diana, go to compare that to what we just. So with the binge eating disorder recovery pathway, that our goal here is to stop the physiological binges and separate out those physiological binges from emotional binges that come from not eating for long periods of time, and then the body kicks in a survival mode, if you will, versus a physiological, or excuse me, an emotional binge, which is usually due to some kind of emotional trigger happening, a fight, you know, someone calling you names on the street, for example. Diana, can you see that pathway on your screen? Sorry, I've just my.
Sorry, Melainie. Yes, the slide is up. It may still be floating over to you.
Yep. Okay. So I'm gonna just walk through that. So then we go through neutrality with food, the intuitive eating, the healthful eating, which again is not a necessary part of this, and on to symptom-free and being neutral with food. And again, like anorexia and bulimia, recovery from binge eating disorder is actually possible. And there has been much debate about this in the community and even among clients themselves. But we do know that many people can recover from binge eating disorder as they can from anorexia and bulimia. The unfortunate piece is that it's just a very, very long period. Let's go to the next slide, which is just a rehab. Logical binges. As we saw with bulimia, not eating all day, by the end of the day you're starving, the body kicks in and says, find food, fried chicken is really good right now. So then we find ourselves feeling out of control with our choices, and we'll actually and in a similar way that we saw for bulimia. To be more, our behaviours are wired in that some of us are wired to be more anorexic in our relationship with food, some of us are wired to be more following the pattern of binge eating disorder. It's not a choice, in other words. So there you go with that physiology of eating patterns. If we go to the next step, the goal, of course, is to have those blood sugar evenly throughout the day. And just as an example, using a client as an example, I worked with a binge eating disorder client, and it took us about, I would say, 2 to 3 years to get to a point where there were evenly spaced meal events throughout the day. That's a long time to work on that, and part of that difficulty, if you will, is for our binge eating disorder clients, there is such a fear of eating that the fear is once I start eating, I won't be able to stop. And the other fear is that if I start to have these meal events earlier in the day, I'm just going to binge at night anyway, and then I'm going to end up eating even more calories than I would otherwise. So this is not helpful. It's a really scary process, and one that takes a very significant amount of trust on behalf of our binge eating disorder clients, and a very special sensitive connection with their clinician. Let's have a look at the nutrition treatment of binge eating disorder. Very similar to what we did earlier, and I'm just going to look at the beginning and the end here with you to give you a sense. We start off with just coffee throughout the day, dinner, and then maybe a snack that's full of some forbidden foods. This is a very common pattern. So then if we get to the next slide, after many, many months, if not a year or two of treatment, hopefully we're able to help the client get to a balanced eating pattern, 3 meals, 3 snacks, and then we continue to work on the variety, the different cuisines, the so-called normal portions, a greater neutrality with food, and those balanced meals throughout the day. So that's our start point towards that world. Let's have a look then at the challenges of recovery for binge eating. I think the biggest challenge for binge eating disorder, above and beyond anorexia and bulimia, is that the recovery timeline appears to be almost double what it is for anorexia and bulimia. The recovery timeline is estimated to be somewhere between 8 and 14 years, and to be honest, we don't really have any great data or research to even support this yet. That's a guesstimate from clinicians in the field. Certainly a lot more research needs to be done. Recovery and treatment is slow and steady. Many of our clients have struggled with binge eating since childhood, so this is a lifelong pattern of eating that has been imprinted in the brain, and to undo that, as you could very well imagine, would take a lot of time. We also are challenged because many of our clinicians are savvy with anorexia and bulimia, but not so with binge eating, so that makes it very difficult as well. There is a weight bias in the clinical world where some of our doctors or people who are not trained with binge eating and not trained around obesity do still think that it's a matter of willpower and one should just be able to control their eating, which we know is clearly not the case. And the general public's belief, which means some of our loved ones may well intentionally say you'll be able to solve your weight problem by going on a diet. And we know for sure that dieting actually worsens binge eating, so it's not the way to go. And we'll go to our next slide. Another challenge in treatment is that weight loss is not the specific goal of treatment. And for my clients who are coming in, they want that to be the goal. But actually the goal of treatment is working on those behaviors that we spoke about so that our clients ultimately are hungry, they're stopping when they're full, and that's it. So we're able to reduce, if not eliminate, the episodes of eating that are events. And if we can reduce those and reduce the episodes of overeating beyond fullness, then we're getting the body and the regulatory system back to a more balanced place. And then we can see what the client's weight will do as a result of changing those behaviors. Biochemical changes can occur in the body that unfortunately with binge eating disorder are irreversible. It can be very difficult for clients who've gained more than 100 pounds, for example, to be able to lose that 100 pounds and keep it off. And that is a very difficult part of working with binge eating for the clients as far as their expectations and their hope for what recovery may bring for them. And therefore, for some clients, they may say that if there's not significant weight loss, then recovery doesn't seem worth it, and therefore they may choose to not put themselves through that hard pathway of what recovery is. So those are some challenges in treatment, but I do want to reiterate that binge eating disorder also, full recovery is possible. And over to you, Diana.
Yeah, thank you so much, Melainie. All that information was so valuable and insightful, and we're so grateful to you for sharing that with us.
You're most welcome.
So for everyone who is viewing this webinar presentation, I'd just like to take a moment to share some of our resources before we come to a close. So if you'd like to get involved with NIDA and some of our initiatives and also learn more about eating disorders, please feel free to visit our website, mynida.org, to check out some of our resources that are all free and available to you. We have the PFN webinar series, which is under the media tab of the NIDA website, and that is where this webinar has been found, and along with some of our other great webinars. We also have our annual NIDA conference that is coming up in October in San Antonio, Texas, from October 16th to the 18th. and we strongly encourage you to join us there. It's going to be a great time filled with tons of information and certainly a wonderful event for all to come and enjoy and learn more. Of course, if you are ever in need of help or information and resources, you can always call NIDA's Information and Referral Helpline at 800-931-27. You can always use our click-to-chat option if you are unable to or uncomfortable giving us a call. That's fine, too. Our NIDA Navigators program is a program that is comprised of trained volunteers who have personal experience with an eating disorder, either through themselves or their loved ones. And that program is available free, and it's there for you to utilize at your discretion. And of course, our NIDA toolkits are wonderful resources that offer lots of information about different types of eating disorders and ways that loved ones can be supportive and learn more about the illnesses. So that brings us to a close, and just to be mindful of everyone's time, we would like to offer to anybody who is interested in submitting any questions you may have. I'm sure Melainie would have no problem receiving those and sharing her insight, and we'll be happy to share those answers with you. So thank you, Melainie, in advance.
You're most welcome, no problem at all.
So again, a huge thank you, Melainie, for this engaging and informative webinar and for taking the time to share your knowledge and experience with all of us, and to all of you for joining us today. You will all receive a short questionnaire by email about this webinar, and we'd appreciate you taking just a minute of your time to offer your feedback and suggestions for future referencing. And of course, if you have any ideas for future webinars, please feel free to let us know through the survey or by emailing me, Diana Calagrides, at nationaleatingdisorders.org. So again, thank you, Melainie. Thank you to all of you who are joining us today, and we look forward to offering you more presentations in the near future.